Today I would like to discuss the concept of contractility as it relates to the heart. The use of the term contractility goes back well over 125 years and was used simply to describe the property associated with the shortening of tissues. Current usage is much more specific and is used in relationship to the contraction of the heart. Originally, the term contraction and contractility were used interchangeably. However, today they have very different meanings. Contractility, as used today, relates to the efficiency of cardiac muscle during a contraction. Currently, there are two terms that are more appropriately used for the word contractility. They are inotropy and homeometric autoregulation. In 1959, Stanley Sarnoff and his associates did some experiments to identify those things that affected the ability of the heart to contract. It was already known that the muscle length prior to contraction determined the amount of tension developed by the cardiac muscle. This is the Frank-Starling relationship. Very early it was recognized that the Frank-Starling curves were due to the change in the change in the overlap of the actin and the myosin. It was obvious to Sarnoff that there were factors of an external nature that changed the force of contraction, so he coined the term homeometric autoregulation, indicating that this response was independent of resting muscle length. To keep things standardized, he used the term heterometric autoregulation for the Frank-Starling phenomenon. Sarnoff and his colleagues were interested in those factors that changed the developed tension without changing the resting muscle length. For their experiments, they looked at the effect on cardiac muscle of stimulating the stellate ganglion, which is the sympathetic output to the heart, and they measured the developed tension. They found that they could produce a family of curves of the length tension relationship by changing the frequency of stimulation. They also showed that the same changes were seen by the infusion of norepinephrine. In order to understand what is going on with the Frank-Starling mechanism and changes in contractility, we need to examine what is happening within the cardiac myocyte during the contraction. The contractile unit of the cardiac muscle is the sarcomere and is composed simplistically of actin and myosin filaments. It is the interaction between these two structures that allows for the active development of tension. Contraction is created by the myosin heads moving along the actin strands. The amount of actin and myosin overlap did not explain how the strength of contraction was increased by outside factors when neither preload or afterload were changed. Sarnoff suggested that it altered something within the cell. We now know that the concentration of calcium in the cell is what triggers the contraction. As a result of the action potential, calcium enters the cell to trigger the release of calcium from the sarcoplasmic reticulum. The calcium then exposes more binding sites on the actin for the myosin heads, allowing for contraction to take place. There are many ways to show changes in contractility. The Frank-Starling curves are probably the best known. These are only valid if afterload is held constant. Changing afterload alters the speed of contraction and thus shifts the curves upward or downward, appearing to change contractility. Another way to look at contractility is by the use of the ventricular pressure volume loops. Here we can see increases in stroke volume as a result of changes in contractility. However, stroke volume is also affected by other factors, both preload, as seen here, And afterload, as presented here, will also change stroke volume. Preload increases stroke volume, while afterload decreases stroke volume. There's only one way of presenting changes in contractility that is independent of preload and afterload, and that is by determining the maximum velocity of shortening, or the Vmax. Sonnenblek and his associates were the first to do this. The device they used is shown here. Unfortunately, the Vmax is not easy to obtain. Here you can see that we have the preload, and they could change the afterload, measure the tension developed, and the maximum velocity of the tension developed. The process involved determining the velocity of shortening at a given preload, and then add additional load to see to measure the change in velocity of shortening. This allows the generation of a load velocity curve that can be extrapolated back to zero load. Where the curves intersect the y-axis is the Vmax. Preload by itself has an effect on the velocity of shortening, as is shown here. In this situation, a papillary muscle is contracted at increasing preloads. And you can see that the velocity of shortening is increased. The same effect is seen with the experiments performed by Sonnenblek. When the preload is changed, then a new curve is generated. Again, the extrapolation of the curve still intersects at zero load because there is not a change in contractility. However, when the experiment is repeated by adding norepinephrine to the bath, the curve shifts to the right, and there is a new Vmax. The mechanism for this change in contractility is all calcium related. Those agonists that increase contractility increase the amount of calcium that is entering the cell, which increases the amount of calcium being released by the sarcoplasmic reticulum. This increase in calcium with the cell binds with the actin to make more binding sites available for the myosin heads to interact with the actin. This increased binding between the actin and the myosin happens without a change in overlap, thus increasing the strength of contraction, or the Vmax. Experimentally, it's difficult to determine contractility accurately, since development of tension is affected by both preload and afterload. The most useful measure is the first derivative of left ventricular pressure, or dPdt. In this figure, left ventricular pressure is shown by the red line, and right ventricular pressure is shown by the green line. You can see that the rate of pressure increase in the left ventricle changes before and after the aortic valve opens. So it's greater before than after. At that point, the afterload starts to slow down and the velocity of pressure development decreases. Therefore, left ventricular dPdt is a good approximation of true contractility. There are a number of substances that increase contractility by increasing the availability of calcium intracellularly. Catecholamines increase the release of calcium by the sarcoplasmic reticulum during the contraction. They also increase the reuptake of calcium, increasing the rate of relaxation. Two examples of the effect of catecholamines are presented here. In this first example, obtained from conscious dogs, we show the recording of the changes of left ventricular pressure, left ventricular DPDT, and aortic pressure. Isoproterenol is also a beta agonist that increases contractility, heart rate, and causes vasodilation, thus decreasing preload and afterload. It is obvious that contractility has increased by the increase in the DPDT. Another catecholamine that increases contractility is norepinephrine. Again, the contractility is increased as seen by the increase in left ventricular DPDT. However, because of the alpha agonistic activity of norepinephrine, both preload and afterload are increased. In order to round out this discussion on contractility, the effect of heart rate must be included. Early studies with skeletal muscle showed that increasing the rate of contraction increased the strength of contraction. This was known to be true as well for cardiac muscle, was shown by Dr. Bowditch. The cause of this effect is an increase in calcium into the cell with the increase in heart rate. This rapidly reaches an equilibrium when the heart rate is changed. In studies with conscious dogs, it would appear that heart rate probably has significantly little effect on the normal heart rate range. In this figure, the effect of increasing heart rate from 120 beats per minute to 250 beats per minute with no increase in DPDT is seen. Similar effects were seen in this study, in which the tracing shows that the heart rate was gradually increased in a stepwise manner from 120 beats per minute to 150 beats per minute, with no significant changes in DPDT. If we are trying to determine the effect of an intervention on contractility, heart rate, preload, and afterload must all be held constant. However, the effect of heart rate is minimal compared to most other interventions that are being examined. Hopefully, this presentation helps you to better understand the meaning of the term cardiac contractility.